Hello and welcome. In this video, we are going to discuss mental status exam in neurological assessment. Mental status examination is one of the components of neurological examination. And essentially, we are trying to understand how well the brain is working in terms of consciousness and cognition. I would like to mention briefly that mental status examination are of two types. In neurology, or in neurological examination, we actually focus on the cognitive function as it relates to the brain itself. While in psychiatry, mental status examination is actually broader. They actually examine broader mental health aspects. So in psychiatry, you will see a detailed mental status examination that includes things like appearance and behavior, speech, mood and effects, thought content and process, perception, cognition, abstract thinking, insight and judgment. So all these are in psychiatric mental status examination. But in neurological mental status examination, we're actually more focused on the brain as an organ and its function. Okay, so it is much shorter. And then we examine things like consciousness, orientation, memory, attention, and intelligence. The components for neurological mental status examination, which we are going to perform here, are consciousness, orientation, memory, and intelligence. I always remember it with COMI, consciousness, orientation, memory, and intelligence. Like in all our videos, I'm going to start by explaining all the theories you need to know about mental status examination, about mental status exam in neurological examination. Then we're going to go ahead to perform the examination itself. If you found this video helpful, please drop a like, subscribe if you haven't already, and turn on your notification bell so that you don't miss the next one. Also share this with your friend who might need it. So like I said, it has various components, which includes consciousness, orientation, memory, and intelligence. The first one is level of consciousness. Now, in consciousness, we are trying to determine the level of awareness of the patient and how well the patient can respond to their surrounding. So in neurological context, we actually use clinical scales to do this. One of the most popular scales we use for this is a clinical scale known as a Glasgow Coma scale, which we use to measure level of consciousness. Another scale I would like to mention here, which is actually used specifically for malaria coma, is a Blantyre Coma scale. But for now, for most neurological exams, you actually make use of Glasgow Coma scale. And this is a clinical scale which is used to measure a person's level of consciousness. And it is composed of 3 tests. We have the eye test, the verbal test, and the motor response test. And all the tests combined will give you a score of 15. Now, the eye test has a highest score of 4. The verbal test has a highest score of 5, whereas the motor test has a highest score of 6. Everything is 15. So 15 is the highest score you will get in a Glasgow Coma scale. Now, in some cases, you might not be able to test all these components. In the eyes, you might not be able to test the eye response if there's something like periorbital swelling, which might not allow the patient to comfortably open the eyes. So you might not be able to get the best response from the patient. In that case, you might not be able to test the eye response. Again, if the patient is intubated, you might not be able to test the verbal response. Now, if the patient is intubated and you're not able to test the verbal response, you add T to the complete score. For instance, if you have something like 70, it means you tested only the eye and the motor. You didn't test the verbal because the patient is intubated. Again, in some cases, you might also not be able to test the motor response. For instance, if the patient is paralyzed or the patient is sedated, you might not be able to get the highest form of response from the patient in motor response. In that case, you might not be able to test the motor. Well, if you're not able to test anyone, make sure you indicate it in the results. So when you're reporting the Glasgow Coma scale response, you always add a bracket where you indicate the various components. For instance, if you have something like a Glasgow Coma scale of 9, the eye response was 2, the verbal response was 2, and the motor response was 5. You actually have to indicate it in the bracket. Now, if you're not able to test any of these, make sure you indicate it in the bracket. And like I said, if the patient is intubated, use T. But if you're not able to test any other one, make sure you indicate it in the bracket while reporting it. Now, for each of these tests, the lowest score you can ever get is 1. That is for eye response, the lowest is 1. For verbal response, the lowest is 1. Then for motor response, the lowest is 1. That is to say, the lowest score you can get from a Glasgow Coma scale is actually 3. The highest is 15. So if you get a Glasgow Coma scale of 15, it means the patient is conscious and fully alert. A Glasgow Coma scale of 3 shows that the patient is completely unresponsive. A Glasgow Coma scale of 8 or less than 8 shows that the patient is actually in a coma. Then from 9 and above shows mild or moderate impairment. Now let us go to each of these tests. Now for the eye opening, like we said, the maximum is 4. Now if the patient can spontaneously open their eyes, then that means it is 4. The score is 4. You give the patient 4. Now, if the patient cannot open their eyes spontaneously, but they can open it to speech or sound, you give the patient 3. Now, if the patient is not able to open their eyes to speech or sound, you try to apply what we call peripheral pain. Now, in peripheral pain, you apply pressure on the nail bed You can do this by taking a pen, a marker, or anything like this, then apply pressure on the nail bed. That's very uncomfortable. So this is what we call peripheral. Applying pressure on the nail bed with something like a pen or a marker or any other smooth object you have. So you apply pain on the nail bed to see if the patient will respond by opening their eyes. If they're not able to open their eyes to pain, you now give them a score of 1, which means there is no eye opening. So that is that for eye response. Now for verbal response, we said that there is a maximum score of 5. If the patient is oriented and converses normally, ask the patient things like, what is your name? Do you know where you are? What time of the day it is? If the patient is able to answer all these and able to converse normally, then we say the patient is oriented and converses normally. Give the patient a score of 5. But if the patient is confused, for instance, you ask them their name, they're not able to record the name, or they say the name of another person, or they're not able to recall exactly where they are, but they can actually converse. Maybe you ask them, where are you? In a hospital setting, they will say they're in a school or in their house. Then that means it's confused conversation. Now you give the patient a score of 4. Now, if the patient mutters inappropriate words, for instance, if you ask them, what is your name? They tell you they want to eat, they like biscuit, they are actually saying things that are not appropriate for the conversation. Give the patient a score of 3. Now, if the patient are actually making incomprehensible sounds that don't make sense, which are not actually words, then you give the patient a score of 2. And if there's no verbal response at all, give the patient a score of 1. Now, for the verbal response, for children between 0 to 2 years that can't converse normally, we have a modified version for them. Now, if the baby interacts appropriately, maybe the baby cools or babbles appropriately and interacts appropriately, we give the baby 5 points for the verbal response. Now, if the baby cries or the baby is crying but is consolable, we give the baby 4 points. If the baby cries but is unconsolable, then we give the baby 3 points. Now, if the baby moans or grunts in response to pain, we give the baby 2 points. And if there's no response at all, we give the baby 1 point. That's for verbal response for children between 0 to 2 years that can't converse. Then the motor response, like we said, the maximum score for motor response is 6 points. Now, if the patient is able to obey command, for instance, if you tell the patient to squeeze your hand, let go of your hand, they're able to obey command appropriately, then we'll give the patient 6 points. Now, if the patient is not able to obey command, then we'll try to apply central pain on the patient to see if the patient can actually localize the pain. Now, like we said, during the verbal response, we applied peripheral pain, but during motor response, we're going to use central pain. Now, to apply central pain, one of the ways to apply central pain is either using what we call the sternal rub, or you apply pressure on the trapezius. So these are some of the ways you can apply central pain on the patient. Now, if you apply the central pain on the patient and the patient moves purposefully or the patient localizes the pain, probably trying to remove your hand from the pain, we give the patient 5 points. Now, if the patient actually withdraws from the pain or pulls away from the pain, then we give the patient 4 points. Now, if there is abnormal flexion to the pain, that is what we call the decorticate posture. The arms will be flexed and the fists clenched, and the hand will actually move towards the core of the body. So this is abnormal flexion to pain. That's the decorticate posture. We give the patient 3 points. But if on application of the pain, there is abnormal extension to the pain, where the arms are extended and rotated, that is decerebrate posturing, you give the patient 2 points. Then if there is no motor response at all in response to the pain, you give the patient 1 point. So like we said, the interpretation, the total score is between 3 to 15. And when you are reporting it in brackets, you put the various components and the scores. Now, if you're not able to measure any of the components, you indicate it in that. Now, if there is intubation, which means you can't even assess verbal response, you add T to the score. Now, if the patient is fully conscious and alert, that is 15. But between 13 to 14, that's mild impairment. Now, 9 to 12 is moderate impairment. Anything 8 or less than 8 is severe impairment and generally indicates coma. Now, for the score of 3, means that the patient is completely unresponsive. Now, in reporting this, if the patient is normal, you can actually say the patient has GCS of 15, fully conscious and alert. Or if there's moderate impairment, you can report it this way: GCS of 11, E3, V3, M5, opens eyes to voice, inappropriate words, localizes pain. Now, apart from the Glasgow Coma scale, we have the Blantyre Coma scale, which is actually used for young children with cerebral malaria. This is what I mentioned it here. But in most cases, in most OSCE scenarios, you get a patient which you can actually use Glasgow Coma scale on. So just note that there's what we call Blantyre Coma scale, which is actually a modified pediatric scale designed for assessing malaria coma in children. Now, after level of consciousness, the next thing we're going to assess in mental status assessment of the neurological examination is the orientation. So in orientation, we are trying to assess the awareness of the patient in 3 dimensions, and they include time, place, and person. Okay, so we're trying to assess if the person actually knows who they are, the place where they are, and the time of the day, and probably the month of the year it is. Now, when someone becomes disoriented, it actually progresses from time to place and person. That is to say, when disorientation happens, it typically progresses from time. That is, you lose orientation of time, you lose the orientation of time first, then you lose that of place, then you lose that of person. So person is actually the most preserved orientation. And by the time someone loses the orientation of person, they must have actually lost the orientation of time and place. So we move from time, place, and person, typically. So in testing the orientation for the person, we actually ask questions like, what is your name? If possible, we can follow up with a question like, what is your date of birth? This is the last to be lost and most concerning if it's impaired. When we are done testing testing the person, and when the person is oriented in person, we'll go over to place. So for the place, we'll ask them, where are you right now? So we can follow up with a question like, what city or country are we in? So these are questions that will help us determine if the person actually knows where they are. Okay, so that's testing for the place orientation. Now, the last one to test for is the time. Okay, so there are various components to time. It can be the day of the week, the date, the month, the year, the season, or time of the day, whether it is morning, afternoon, or evening. So this is actually the first to be lost when a patient is confused. So the patient might not be able to determine if this is morning, afternoon, or evening. So like we said, disorientation occurs from time, place. Person is actually the last to be lost. So to assess for time, we can actually ask the patient, what is today's date? What time of the day is it? Now when we are done with orientation, the next component of the mental status exam is memory. Now there are various types of memory. The first one is what we call the immediate memory. The second one is the short-term memory. Then the last one is the long-term memory. Now, the immediate memory, or what we call attention or working memory, is actually the shortest, and the duration is between seconds. We test it using what we call the digit span. In the digit span, we actually mention 3 digits and ask the patient to repeat. Something like 5, 8, 2. Then the patient repeats 5, 8, 2. Then you add another digit at the end. Something like 5, 8, 2, 7. The patient will repeat 5, 8, 2, 7. So you continue that way until the patient is able to fail. Typically, a patient is able to go till around 5 to 9 digits. So that's called the digit span. We also have the backward digit span, where we mention numbers, we say something like 7, 3. Then we'll ask the patient to mention it in reverse. So the patient will actually mention something like 3, 7. So the patient is actually typically able to get between 3 to 5 in the reverse or the backward digit span. We use the digit span to test for immediate memory or attention or working memory, which lasts for seconds. Apart from digit span, you can also use several other tests to test for the immediate memory or attention of the patient. They include serial 7. So this is a test where you tell the patient to subtract 7 from 100. Okay, so they subtract 7 from 100, then they subtract 7 from the result. So they keep on going until they fail. Typically, the patient should be able to get up to 5 of it. Now, for less educated patients, we have what we call the serial 3, where they subtract 3 from 20. They subtract 3 from the results, subtract 3 again till they're able to fail. Probably they should be able to get approximately 7 calculations. So we use the serial 7 or the serial 3 to also test for attention. Now, apart from this digit span, serial 7 or serial 3, we can also use what we call spelling word backwards, where the patient will try to spell the word W-O-R-L-D backwards. So this actually tests for the concentration and the sequencing ability of the patient. Now, all these tests will actually depend on the educational level or the knowledge or the age of the patient. For the short-term memory or the recent memory, which actually lasts minutes to days, we use what we call the 3-word recall to test for this. So this is where we'll mention 3 words randomly for the patient. Something like we can tell the patient, mention 3 words randomly to the patient, then ask the patient to recall these words after a few minutes. Now, to perform this test, you first of all start by mentioning 3 random words. Probably something like apple, table, bag. Then make sure the patient registers these words by telling them to repeat it. Okay, so make sure they register by telling them to repeat it. Then tell them that you ask them for these 3 words in a couple of minutes, that they should try to remember it. Okay, so you mention those words, make sure the patient repeats it to you to ensure that they actually heard you. Then tell them that they should remember these words, that you ask them for it in a couple of minutes. And when you're done with this, you can proceed with other aspects of the examination. Then after a couple of minutes, you ask them to recall those words. So for the 3-word recall, we have these procedures. We have the registration, where you mention the words to the patient, ask the patient to repeat them to ensure that the patient registers those words in their memory. Then distract them by performing other aspects of the examination. So after a couple of minutes, you now come back and ask them to recall. So those are the procedures we follow in the 3-word recall. Now, that is used to test for what we call the short-term or the recent memory, which lasts between minutes to days. Now, for the long-term memory, which is actually supposed to last between months to years, we test with things like the personal history of the patient, then popular historical events. So to test for the long-term memory, you can use the personal history of the patient, such as when is your birthday, which school did you attend, to test for long-term memory. You can also use historical events such as who is the president, when was independence, to test for the long-term and the remote memory. So this is the way to test for the immediate, the short-term, and the long-term memory. Now, when we are done with the memory, the final part of the mental status examination is the intelligence aspect, where we try to test the intelligence of the patient by asking age-appropriate general questions. So for adults, you can ask questions like, how many weeks are in a year? You can also ask simple calculations to actually determine the intelligence of the patient, something like 45 plus 38 and stuff like that. Then for children, you can ask them much simpler mathematics, such as 5 plus 3, name 3 animals, probably draw a person test, depending on the level of the patient. Intelligence test actually depends on the level of the patient. So when you're done with the general knowledge questions, you can also test intelligence using what we call the abstract thinking test. So we tell the patient to interpret a proverb. So you can say something like, what does "don't cry over a spilled milk" mean, to test the patient? So this tests the abstract thinking of the patient. So in intelligence, you use general questions, then also test the abstract thinking of the patient. If you found this video helpful, please drop a like, subscribe if you haven't already, and turn on your notification bell so that you don't miss the next one. Also share this with your friend who might need it. Now, in the previous part of the video, we explained the theories involved in mental status examination in neurological exam. In this video, we're going to demonstrate it. Now, like we said, in every examination you have, we have the pre-exam, we have the exam itself, and the post-exam. In the pre-exam, you greet your patient, introduce yourself, then take permission from the patient, then you perform your hand hygiene. Then in the post-exam, you thank your patient and probably explain the results of your examination to the patient. That is for the pre and the post-exam, which is constant for every examination in any OSCE scenario. Now, the examination itself is what we are going to discuss. So I'll start by performing my pre-exam by greeting the patient, introducing myself, trying to create rapport, then taking permission and my hand hygiene. Hello, good afternoon.
Good afternoon.
My name is Dr. Henry, and I will try to examine your mental state by asking you a series of questions. Can I go ahead? Good. So I'll perform my hand hygiene. Now, like we said, there are various components to the mental status examination in neurological stations. The first is level of consciousness, which we are going to perform using the Glasgow Coma scale. And like we said, the Glasgow Coma scale has 3 components or 3 tests: the eye test, the verbal test, and the motor test. Now, looking at our patient, his eyes is open spontaneously even before we started the test. So we're going to give him the highest score for the eye test, which is actually 4. Now, for the verbal response, when I greeted him, I introduced myself and sought permission to perform this, he responded appropriately. So automatically, we are going to give him the highest score for verbal response, which is 5. We can also go ahead to ask him series of questions, at least to ensure that the verbal response is supposed to be 5. So, sir, can you please tell me your name?
My name is Igwe Valentine.
Okay. You know where you are?
Yes.
So where are you?
At the hospital.
Okay. So what time of the day is it?
It's afternoon.
Okay, it's afternoon. Okay, so we can see that he can converse appropriately and he's oriented. So we'll give him the verbal score of 5, which is the highest for verbal response. Then for motor response, we are going to start by checking if you can actually obey commands. Just squeeze my 2 fingers. Okay, no. You can just, okay. Then try to squeeze it. Okay, you can now release it. Good. So it shows that he can actually obey commands. So we give him the highest for motor. That means that our patient will have a GCS score of 15, which shows that our patient is fully conscious and alert. That is that for consciousness. So next component is the orientation, where we're going to ask series of questions to determine if he's oriented in person, place, and time. Sir, please, what is your name?
I'm Igwe Valentine.
Okay. Can you remember your date of birth?
Yes.
Okay. Tell me your date of birth.
4th January.
So where are we right now?
In the hospital.
So what is today's date?
Today's date is 30th of October 2025.
Okay. What time of the day is it?
It's afternoon.
So with this, we've been able to test the patient's orientation in person, place, and time. And we can say that our patient is well oriented in place, person, and time. Now, after orientation, the next is memory, where we are going to test the immediate working memory or the attention of the patient. Then we're going to test the short-term memory and also going to test the long-term memory. Now, for the attention or the immediate memory, we're going to use the serial 7. Sir, okay, can you subtract 7 from 100?
93.
Okay. Can you subtract 7 from 93?
86.
Okay. Can you subtract 7 from 86?
79.
Okay. Can you subtract 7 from 79?
72.
Okay. Can you subtract 7 from 72?
65.
Okay. Can you subtract 7 from 65?
58.
Okay. Can you subtract 7 from 58?
51.
So typically, you can actually stop after 5 calculations. You can see that the attention of a patient is intact. Then again, apart from the serial 7, if the person is less educated or a small child, you can use the serial 3. You can also use the digit span we talked about earlier in the theory aspect. So with this, we are done with the attention. Then we'll head over to the short-term memory, where we are going to start by telling our patient 3 words and tell them to remember it. Then we'll go over to other aspects of the examination. Then at the end, we'll ask them to remember those 3 words. Okay? So, sir, I'm going to tell you 3 words now. Okay? I want you to repeat the words to me. Then, after some minutes, I'm going to ask you those 3 words again. Okay? Okay? Apple, table, bag.
Right. Apple, table, bag.
Okay? I want you to remember these 3 words. I'll go ahead to do other things. Then at the end, I'll ask you to record these 3 words for me. Okay? We can actually go ahead to test the long-term memory of the patient. Then we can now go back to asking to record those words, which we actually mentioned now. In testing the remote memory of the patient, we can ask them personal history questions or historical events, which they can actually remember. Can you remember your date of birth, sir? Okay, what is your date of birth?
4th January.
What was the year of independence in this country?
1960. October.
So with this, we've been able to assess the remote memory of the patient. Now, sir, earlier in this test, I gave you 3 words, which I said you're going to recall for me at the end. So can you remember those 3 words? Okay, mention them too.
Apple, table, bag.
Good. So with this, it shows that the short-term memory of our patient is intact. The final aspect of this is the intelligence test. Then we're going to ask the patient a general knowledge question to see if he can answer. Probably give him a simple calculation to see if he can perform it. And then probably we're going to give him an abstract or proverbial saying to test his abstract thinking. Okay? So, sir, how many weeks are there in a year?
52.
52. Okay. Okay. 45 plus 38.
45 plus 38. 83.
Okay. So we're going to go ahead to test the abstract thinking by giving them a proverbial saying to see if they can interpret it. Okay. So, sir, when we say something like a stitch in time saves 9, what do we mean?
It means that early preparation can save you a lot of stress in the future.
Okay. So, which is good. So, the abstract thinking is intact. So, with this, we've come to the end of the examination. We actually thank our patients, then report our findings. So, thank you for the examination. Thank you for allowing me to examine you. So, when we are done with that, we can actually report our finding. After the post-exam, we can actually report it this way. Mental status examination reveals GCS score of 15. Our patient is oriented to person, place, and time. Short-term memory is intact, evidenced by the 3 words recalled after 5 minutes. Long-term memory is intact. Attention is intact, as evidenced by the serial 7 tests. Overall cognitive function appears normal. Thanks.